Okay. Thank you very much, Madam Chair. I'm here to present Senate Bill 41, which will require transparency and rein in abusive practices by pharmacy benefit managers that are escalating the cost of prescription drugs and killing community pharmacies. I want to note that recent amendments conform the bill to the health trailer bill that created licensure for PBMs, and we're grateful to the administration for its collaboration. So should the bill pass out today, we will amend the licensure out of this bill as it is existing law. And I'm happy to accept the amendments in the committee analysis as well. PBMs started out as small administrative entities created by health plans to help put together their formularies, and it was an administrative function. Fast forward several decades, and PBMs are now corporate behemoths that are often bigger than the health plans, and frankly are combined with health plans or own health plans. They own their own pharmacies, mail order pharmacies that they effectively try to force consumers to use instead of community pharmacies. They've structured their compensation in a way where the higher the drug price, the more money they make because of the way rebates are structured. And it's just a series of abusive practices that are not to the benefit of patients and not to the benefit of costs or containing costs in the healthcare system. And the destruction of community pharmacies is very severe because pharmacists play a critical role in the healthcare system. And while some people may want to do a mail order pharmacy, for many people that simply doesn't work. And the practices with pharmacies are, I think, particularly abusive for anyone who's ever had a situation where you're told that if you go through the mail order, you get a 90-day supply. If you want to go to your neighborhood pharmacy, you only get a 30-day supply. That's one of the practices PBMs use to try to effectively force people to use their mail order pharmacies. There is broad bipartisan support for ending these practices, and both in Congress and in this legislature. And this bill will prohibit practices that steer patients towards PBM's own mail order pharmacies and away from community pharmacies. It will also move away from spread pricing and will prevent PBMs from pocketing a portion of rebates, which is what gives them the incentive to favor high cost drugs. And of course, licensure, which is now part of the budget. This is a reform that is way, way, way overdue. This committee passed and the legislature passed a similar bill last year. While the governor did veto it, we're optimistic that we'll be able to work with the administration, particularly given the licensure being placed in the budget. And we look forward to that conversation. So with that, I respectfully ask for your aye vote on SB 41. With me today to testify is Clint Hopkins, a pharmacist and owner of Pucci's Pharmacy here in Sacramento, and Dr. Sonia Frausto, the owner of 10 Acres Pharmacy.
Thank you. You'll each have 2 minutes.
Good afternoon, Madam Chair and members. I am Dr. Clint Hopkins, pharmacist and owner of Pucci's Pharmacy, independently owned here in Sacramento since 1930. PBMs now dominate not only the pharmacy market, but also the healthcare market at large. They own the health plans, the pharmacy down the street, the mail order pharmacy to where they steer our patients, and they dictate contracts that underpay and force pharmacies to close. Even before the Rite Aid closures, there were numerous other community pharmacies closing their doors, creating pharmacy deserts. We do our best to care for these patients, but too often we have to explain that the drugs they take are being reimbursed below the acquisition cost, a large part of the reason that their previous pharmacy closed their doors. Every day it seems we spend more time explaining to patients we cannot help, why we cannot help them, and trying to help them navigate the system than we do counseling patients who are actually picking up medications from our pharmacies. PBMs limit drugs which can be dispensed locally and reserve the most profitable drugs for dispensing from their own pharmacies. Just yesterday, we were contacted by a patient who was forced to use a PBM-owned mail-order pharmacy for his specialty medication. This patient happens to be a federal employee who is forced to use the PBM-owned Caremark pharmacy who manages the benefits for federal employees. His medication is a generic that doesn't cost very much. He's not happy with the mail service. He's run out of meds multiple times due to their delays, missing doses, and putting him at risk of disease, which could be prevented by allowing him local pharmacy access. And then the kicker, they've been charging him a $60 copay each month when he could be just paying $50 cash out of pocket for this specialty medication from a local pharmacy like mine or Sonia's, and had the medication the same day. Unfortunately, he's not an exception. Just last week, another patient, a child of 8 months old, who is being forced to use specialty pharmacy for sildenafil liquid for pulmonary hypertension. The average pharmacy would charge around $120 for a bottle of this medication. We can observe from claims data that CVS will likely pay themselves in excess of $1,300 for the same medication sitting on the shelf in my pharmacy. And his parents will have to wait for this crucial medication to be shipped from a mail service pharmacy in another state. For far too long, PBMs have operated in the shadows, extracting exorbitant amounts of money from the system they've designed. Without this legislation, PBMs will continue to run afoul, causing more pharmacies to close, local jobs to be lost, and patients to lose access to health care in their communities. I respectfully ask for your aye vote on SB 41.
Thank you. You can go ahead.
Madam Chair, members of the committee, I'm going to get emotional, so I apologize in advance. My name is Sonia. I'm the owner of 10 Acres Pharmacy here in the Land Park area. As a local pharmacy, we are deeply rooted in our community. We've built a welcoming space where care goes beyond prescriptions, where relationships are built on communication, respect, and compassion. I work every day to empower my patients, but it's become nearly impossible to focus on their needs while fighting to keep my doors open. I'm managing the pennies, literally the pennies, and determining what my reimbursement is because it comes daily. PBMs often reimburse us under what we paid for the drug. So I might pay $105 for a drug and being reimbursed $50, which leaves me $55 short. That doesn't even take into account my staff, my utilities, or even my loans. This is truly unsustainable, and it creates a situation where I have to decide whether I can even take care of this patient or I have to send them to a mail order or a chain block pharmacy that's down the street. This is just to keep my doors open. This is not what I signed up for when I became a pharmacist, and this is not what any of us pledged to do when we took our oath. In 2024, our pharmacy had to let patients who had HIV, cancer, and heart disease know we could no longer fill their medications because we were being reimbursed below cost. These aren't rare situations. They're happening every single day. The more prescriptions we fill, the more money we lose, the more financially unsustainable this is. Now we have 4 pharmacies that have closed within a 5-mile radius of my store, and I'm now having to choose whether or not I can take parents, grandparents, or children because I'm losing money every single time. It's very painful to turn them away. While most people don't realize why their local pharmacy closes, I can tell you firsthand. It is the unchecked powers of the PBMs that is driving us out. And it's not just in Sacramento, it's across California. My friends down in Fresno have owned pharmacies that have helped COVID vaccines and distributed them, and guess what? They're now closed. We need real action. We need you to sign and support SB 41 to stop the PBMs from reimbursing below cost and driving pharmacies like mine out of business. Pharmacies are essential. Our patients cannot continue to suffer. Our pharmacies cannot continue to disappear. And I respectfully ask and respect your support. Thank you.
Thank you for that testimony. It's very appreciated. All those in the hearing room who would like to offer a Me Too in support, please come state your name, affiliation, and position on the bill.
Good afternoon. Shira Spector with Stone Advocacy on behalf of the California Orthopedic Association in support. Thank you.
Thank you, Madam Chair and members. Megan Subers on behalf of the Los Angeles LGBT Center, co-sponsor and support. Thank you.
Clifton Wilson on behalf of the California State Association of Psychiatrists, as well as the California Academy of Child and Adolescent Psychiatry, both in support. Thank you.
Good afternoon. Michelle Johnston with the National Multiple Sclerosis Society on behalf of myself and others living with MS in support.
Fred Notwell representing the Pharmaceutical Research and Manufacturers of America in support. Thank you.
Good afternoon, Madam Chair and members. Andres Ramirez with Blue Shield of California in strong support. Thank you.
Jennifer Snyder on behalf of the California Life Sciences and the National Association of Chain Drug Stores in support.
Hello, my name is Celine Chandler. I'm a licensed pharmacist. I just completed residency at UC Davis Health, and I support this bill. Thank you.
Erin Gilbert for USC Keck School of Medicine in support.
Sarah Nocito on behalf of the ALS Association in support. I'm Isaiah Sybeth, and I'm a Touro University student, a pharmacy student, and I am in strong support.
Chair and members, Kathy Mossberg on behalf of San Francisco AIDS Foundation, one of the proud co-sponsors, as well as APLA Health, both in support.
Hi there, my name is Andrew Gaboris. I'm a student pharmacist from Loma Linda University, and I support this bill.
Kate Conley with Vitamin Group on behalf of the California Society of Health System Pharmacists in strong support.
Hi, I'm Dr. Archie Malhotra, and I'm only representing myself. I support this bill.
Good afternoon. I'm Sheldon Finn. I'm the oncology pharmacist and professor and the dean for California North State University. I strongly support this bill. Thank you.
I'm Dr. Hongmin Wan. I strongly support this.
Good afternoon. Liz Helms, President and CEO of California Chronic Care Coalition, co-sponsor of this very important bill and in strong support.
Tim Madden, representing the California Rheumatology Alliance in support.
Liz Mailer on behalf of Indivisible California State Strong and the 80 local groups that we represent in strong support, and incidentally, a regular customer at 10 Acres Pharmacy in strong support of the bill.
Kevin Guzman with the California Medical Association in support.
Gilbert Lara here on behalf of Biocom California in support.
Hello, my name is Ulysses Rosales, student pharmacist from Touro University, California, in strong support of SB 41.
Hello, my name is Asada Sikhan-Chan, student pharmacist at Touro University. I strongly support SB 41.
Good afternoon. My name is Shauna Casillas from Touro University in strong support of SB 41.
Hello, my name is Ken Salvador. I am a student pharmacist and in support for this bill.
Katie Van Dynes with Health Access California in support. Thank you.
Hi, my name is Carly Trin, a student pharmacist from UCSF, and I strongly support this bill.
Hello, my name is Judy Rose Barber, and I'm a pharmacy resident from UCSF, and I strongly support this bill.
Hi, my name is Kelvin Kwok. I'm a pharmacist and a faculty member of the City College of San Francisco Pharmacy Technician Program. I'm in strong support of SB 41.
Hello, I'm Satinder Sandhu. I'm a local pharmacist, and I'm strongly support this bill.
Ann Sodergren on behalf of the California State Board of Pharmacy in support.
Hamza Ziada. I'm a registered pharmacist on behalf of Walgreens and every pharmacist I know. I strongly support this bill.
Hi, Nadela Vizcarra, pharmacy student at Touro University. I strongly support SB 41.
Hello, my name is John Bundo, intern pharmacist at 10 Acres Pharmacy and student at California North State University, and I support this bill.
Good afternoon. My name is Ethan George. I'm a student pharmacist at Western University of Health Sciences, and I strongly support this bill.
Hi, I'm Vicky Tran. I'm a student pharmacist, and I strongly support this bill.
Hi, my name is Prabjot Kaur. I am a student pharmacist, and I support SB 41.
Hi, my name is Randy Nguyen. I'm a student pharmacist at Western University, and I strongly support this bill.
Hello, my name is Anna Tran. I'm a student pharmacist at Western University, and I strongly support this bill.
Hi, I'm Alexandria Young. I'm a student pharmacist at Chapman University, and I also strongly support SB 41.
Hi, my name is Sang-Yoon Kim. I'm a student pharmacist at Chapman University. I'm strongly supporting SB 41. Thank you.
Hi, my name is Sean Kim. I'm a pharmacist serving pharmacy at California Pharmacists Association. I strongly support SB 41.
Hello, I'm Giovanni Hernandez from the California Pharmacists Association, and I strongly support SB 41.
Madam Chair and members, Rand Martin on behalf of the AIDS Healthcare Foundation, which operates 12 pharmacies across the state in strong support of this bill. Thank you.
Hello, I'm Dr. Pete Tenorelli, pharmacist, and I strongly support this bill.
Hi, my name is Shahana Rasan. I'm a pharmacist and assistant professor at California Northeast State University, and I support SB41. Thank you.
Hello, I'm Tariq Qasim, and I'm a pharmacist. I'm in support of this bill. Thank you.
Hello, I'm Dr. Allison Hom. I'm a registered pharmacist, and I support this bill.
Dr. Wally Mente, pharmacist, and I'm in support of this bill. Thank you.
Hi, my name is Angela Sorio. I'm a student pharmacist, and I support this bill.
My name is Sarah Nguyen. I'm a student pharmacist at California North State University, and I strongly support this bill.
My name is Harleen Bogan. I'm a student pharmacist at California North State University, and I support SB41.
I'm Jishan Sidhu, P4 student at CNU, and I support SB41.
My name is Vanshpreet Singh. I'm a student at California North State University, and I support this bill.
I'm Suzanne Clark at California North State University, and I support this bill.
Ryan Spencer with the Crohn's and Colitis Foundation in support.
Susan Bonilla on behalf of the California Pharmacist Association, co-sponsors of the bill, and very strong support. Thank you.
Cher Gonzalez on behalf of my clients, the American Diabetes Association, as well as the Bleeding Disorders Council of California, formerly known as the Hemophilia Council of California, all in strong support. Thank you.
Thank you. Are there any primary witnesses in opposition to the bill? Please come forward. There are two primary witnesses in opposition. Thank you. You'll each have 2 minutes.
There we go. Good afternoon, Chair and members. Allison Ramey here today on behalf of the Pharmaceutical Care Management Association in opposition to SB 41. It's worth noting that SB 41 is a reintroduction of SB 966, which was passed by this legislature but vetoed by the governor last session, with the veto message being that he wanted greater transparency across the drug supply chain. This legislature just last week passed AB 116, the Health Budget Trailer Bill, which achieved many of those goals for the governor. PBMs will now be licensed and regulated at the Department of Managed Healthcare and required to report an extensive amount of data to the Office of Healthcare Affordability, including claims data, contract terms, reimbursement rates at independent pharmacies versus affiliate pharmacies, and a whole lot more. With that data, this legislature will soon be informed and able to make educated policy decisions about how else to regulate the drug supply chain and specifically PBMs. SB 41 goes far in that it proposes additional policy changes that take away client choice and tie the hands of PBMs in their negotiations against drug manufacturers. Left unchecked, we are trusting that drug manufacturers will lower the price, the list price that they set out of the kindness of their hearts. I don't think that that world exists, and as a result, our concern is that the price of prescription drugs will only go up for consumers and the patients that we are trying to make them more affordable for. It's important to remind this committee that PBM clients do not have to use PBMs. PBM clients being unions, the state, plans, large employers make the decision to use PBMs because they save them money. Nothing in SB 41 will lower the cost of prescription drugs for patients, and while we appreciate the time and work that the chair and this committee have put into this bill and this issue, we remain opposed out of concern that it will only increase the cost of prescription drugs, and we urge your no vote.
Thank you. Go ahead.
Thank you. Madam Chair, members, John Winger here on behalf of America's Health Insurance Plans. We're the National Trade Association for the Health Plans. As PCMA stated, our health plans voluntarily enter into arrangements with PBMs to lower their drug spend.
But in the interest of time, there's multiple parts of the bill that we think would increase costs, but in the interest of time, just focus on two things that the plans generally have issues with in the bill. One is around ERISA preemption, and the second is around client choice. And so I think there's multiple provisions of this bill that we believe violate ERISA. There was a 2020 ERISA court case that was upheld unanimously by the Supreme Court that affirmed laws are preempted by ERISA when they impact the core function of health plan administration or directly relate to the health plan and their benefit design. And we think there's multiple provisions of this bill that violate ERISA. On the client choice, as was mentioned by PCMA, we think that the PBMs offer an array of choices to the client on how they want to pay for the services. Some of those arrangements can be done in a way to kind of mitigate risk on the payer side. This bill would essentially get rid of those options, and so we do have issues with that as well. And so for those reasons, we are opposed.
Thank you. Any others in the hearing room that would like to offer an opposition position on the bill?
Madam Chair and members, Stephanie Watkins on behalf of the Association of California Life and Health Insurance Companies, also opposed.
Good afternoon, Olga Shiloh on behalf of the California Association of Health Plans, also opposed. Thank you.
Thank you. With that, seeing no other opposition, I will bring it back to the committee for any comments or questions. Assemblymember Sharp Collins.
Thank you so much for bringing forth the bill, Senator. I do have a question of clarification to the opposition, and I know the opposition, you stated that the way the bill is currently written, that it will not lower the prices of the prescriptions to the consumers. And so if that is the case, then what other alternatives do we have? What options? So what all could we actually do to lower the prices for the consumers?
Well, I mean, I think one thing that we try to do as PBMs is, to the extent that there are generics available, those are what we are encouraging and have preferred placement on formularies. What we see happen oftentimes is drug manufacturers that actually do everything they can to prevent generics from coming to market because they don't want that competition. I don't know that that's necessarily something that this legislature can tackle, but some of pharma's tactics to reduce competition stand directly in the way of the ability to have lower cost drugs available to consumers.
Please.
Yeah, I mean, clearly there are issues to deal with the pharmaceutical industry, and this legislature has done that, and it's, you know, there's more work to be done in Congress as well. But we know that in addition to whatever issues with pharma, that PBMs also escalate drug costs, because the way one of the practices we're banning in this bill, which again, licensure is great, it's supported, I'm glad it went in the budget, that doesn't ban any particular practices. The way that PBMs get compensated via taking a cut of the rebates that they negotiate with the drug manufacturers means the higher the drug cost, the higher the rebate, the higher their take. And so that's why sometimes on drug formularies, for example, lower cost insulin, or sometimes only higher cost insulin is on the drug formulary because the PBMs make more money from it. So, you know, there are a lot. So they are absolutely contributing to cost escalations.
I'm just noticing, did you want to comment? Because you have some disagreement.
Yeah, I would just say we fundamentally disagree with that. I mean, PBMs get hired to negotiate the lowest net price on the formulary as possible, and those rebates go towards reducing the overall drug spend. And it's been seen in the SB 17 reports that it helps to lower and keep premiums down. So we would just fundamentally disagree with that. And I think to your original point, we would just say stop taking tools away in the tool chest when it comes to being able to negotiate drug prices. I mean, I was around for AB 339, the Gordon bill, which was kind of capping the copay, but it also had provisions in there that kind of mandated where we had to place drugs on certain formularies, which essentially gave our playbook away on being able to negotiate. And so things like that have made it tougher to negotiate. There's things in this bill around banning exclusionary contracts to where it would make it tougher to do formulary placement, which would allow us to lower the cost of the drug. And so I think just, allowing our tools to remain in the tool chest would be our ask.
Thank you.
I'll add to that when drugs go generic, PBMs often keep the brand name on their formulary for months and years after those drugs do go generic. I have examples that I can provide you, such as Vyvanse. Vyvanse is now generic. The generic costs a fourth of what the brand name cost, but the brand name is required by some plans. It's called the DAW9 program. So even though the generic is available and it's cheap and we can get it, the plan prefers the brand, and the patient may have a copay that's higher than what they would pay out of pocket for the generic. Not only Vyvanse, but there's inhalers. There's, name some other examples, Sonia, insulins.
Farxiga came out generic last year. Farxiga cost about $600. The generic's $150. Patients have to pay, usually their $2,000 deductible at the beginning of the year. They're paying most of that cost, $400 to $600 for this prescription, even though there's a generic available, because the insurance plan requires that the brand be billed, which is not fair. So when we talk to patients about a cash-based program for them so that they can save money, which most of our patients who are over 65 who utilize this bill are living on limited incomes, we offer the generic option for them and also let them know that if we do run a cash for this prescription, particularly the generic, that it will be not applied to the deductible, and this is to save them money.
Go ahead, Senator.
Yeah, thank you, Manager. I will just say, when I first started getting involved in this, and the health plans associations all came out opposed to it, I was really confused at first, because if you're a payer, then these practices are not in your interest. I learned over time that because we have basically integration between health plans and PBMs and mutual ownership, or one owns the other, that helped explain it. And I'm grateful that Blue Shield, which was not formally in support of the bill last year, but this year is formally in support, because I think that shows that if you're a payer, this is a bill that, frankly, you should be supporting, and that integration, I think, distorts the whole system.
Assemblymember Patel.
Senator, I want to thank you for bringing this bill forward. It does bring to light some very tricky situations for patients and payers that have been out there, and our small business owners who are our pharmacies, our local pharmacies. We've been talking about PBMs in Health Committee this year quite a lot, and we've made a lot of progress as well. A question for both your side as well as the opposition, support and opposition. As a scientist, I look for data. So what is the specific data or lack thereof that has driven you to your position on this bill? I think we have read, as just consumers of media in general, article after article in mainstream and specific press about the challenges with PBMs and how it's increasing the cost of pharmaceutical access to patients. Some of the anecdotes that you've shared are even relatable to me. If I go through my local pharmacy, I can only get a 30-day supply. If I want more than that, with paying that copay over and over and over again, I want to try to avoid that. If I go through the mail order, then I can get the 90-day supply, but the price is significantly different. So I'm not the only one that goes through this. You've cited that example. I feel it. And to Senator, I feel you as well with the comment. I was confused why our health plans aren't also in support of your bill, and then understanding the interconnectivity of the relationships, it definitely helps shed some light to that, to why they're opposed. But what is the data that you have on the support side for this? I'm sure it's vast.
Yeah, we're happy to provide. There's quite a few studies about the impacts of the rebates and the spread pricing, and just the whole model. And so we're happy to provide that to you. And there have been major exposés in the Wall Street Journal and the New York Times and other publications about PBM abusive practices, but there's also been a lot of analysis done, including in Congress, where there's been bipartisan support and oversight. So we're happy to provide that data.
Yeah, thank you. And for the opposition, what data do you lean on to back up your position that it will not help bring down the cost of pharmaceuticals?
Well, I think what we're looking to is a lot of the data that's going to be provided to you all and to the Office of Healthcare Affordability. There's been a lot of finger pointing over the last decade here in this legislature between PBMs, drug manufacturers, to a lesser extent, the independent pharmacies. And we think that that data will answer the question, are independent pharmacies being reimbursed less than the affiliate pharmacies? Are the rebates to blame? Rebates get so much time and attention, but really those savings that are negotiated are passed on to the client, 95% plus. And a lot of the PBMs are making the decision proactively to pass on 100% now. So let's see what the data says and then make these policy decisions rather than taking away the tools PBMs have and leaving it to pharma to set the price.
Well, I certainly do appreciate the anticipating getting that data with this budget trailer bill that we have. When do we anticipate getting the first batch of data?
I think it's 2027 that the first batch will be reported, and it has a look back period. So it's 2026. Let me correct myself. It is 2026, but there's a look back on the data that's going to be reported. So you can take a look at what it was and where it's going and better understand. I think it is an opportunity for people to, again, make sound policy decisions that are rooted in data rather than just assuming that these policy proposed in this bill is going to make a difference.
Thank you. And to the Senator, as a follow-up question, data is wonderful, and I'm looking forward to that in a couple years. But looking at your bill, there's nothing that prohibits the data collection happening. And in the meantime, we can still move forward.
Yeah, and just to be clear, like this is, when we put this bill together, this is not like we have this new novel idea about how to address PBMs. These are policies that have been percolating in Congress and state legislatures, red and blue, around the country. You know, when the governor's staff approached us and said and asked what we thought about putting licensure in the budget, I thought it was a good idea, and I think the rationale is let's get that stood up quickly as opposed to waiting until next year's budget to stand it up. And I knew that the opposition would immediately say, "Oh, we got licensure, we don't need anything else." And as important as licensure is and the data, we know what practices are happening, and so I agree. We should address those practices now because they're having negative impacts now.
Thank you. Thank you.
Thank you. I just wanted to pick up Assemblymember Patel on your query around data and evidence to be able to support. So I just wanted to highlight a couple things that the senator highlighted. One is that there are three major PBM providers. Two of those, Optum has a parent company of United Healthcare. United Health Group, which is a part of the insurance company United Healthcare, and Express Scripts is owned by Cigna. Between those two, I think they own, with CVS Caremark, more than 50% or 60%, 80% of the market. And I just had the pleasure of talking to somebody today, a stakeholder, about this bill, who shared with me that they were working on PBM reform from 1989. So we have been trying to desperately do something in this area in the state of California for quite a while. In just a recent other metrics I would offer is that in the U.S., the PBM industry in 2022 alone was a $482.4 billion industry. In 2024, $573.27 billion industry. In the meantime, the cost of prescription drugs continue to impact affordability of healthcare, with plans paying about $13.6 billion for prescription drugs in 2023 alone. And prescription drugs costs have increased by 10.8% in 2023. Which is the total median medical expenses have only increased by 4%, which is still astronomical. Premiums by 6.2% during that same time period. So there's been just an astronomical increase in the cost of drugs over time, as well as the fact that during a 10-year period, nearly 30% of pharmacies, independent pharmacies, have closed. So we have a lot of indicators of rising cost of healthcare, rising cost of drugs, incidents of increased market share, and vertical integration of PBMs with with insurance providers. Certainly, a lot of money being made, and a lot of money being taken out of consumers and patients' pockets during that time period. So, Senator, I'm very thankful to you for persevering and moving forward with what and I'm sure our consultant here, Scott Baines, would call a kitchen sink of a bill related to PBM reform, not only around the need for greater transparency, which I am thankful we have an ability to do that and get the additional data that we need, but also to be able to provide an opportunity for the many different reforms around practice that have caused much of this increase in drug costs and near elimination of a very vital component of our healthcare industry as well in the pharmacies. I don't see any other questions. I know that there were a lot of amendments. Oh, we do? Oh, Ms. Caloza has a question. I know that there were a lot of amendments that we were able to take, and I thank you for working with the committee to be able to ensure that we had a very tight bill, even though it was a kitchen sink. And with that, I will have Assemblymember Caloza offer some.
Thank you, Chair Bonta, for tackling this issue and for the author for, again, taking on another easy issue before our committees. I just wanted to follow up because I know PBMs, as we heard from our chair, is such a complicated issue. We're going over a lot of terminology, that many of us are still really digging deep on. If you're watching, I have a lot of also local pharmacies in my district that have reached out about this bill. And just wanted to get maybe a little bit more information for folks listening to explain some of the nuances of some of the terms that have been mentioned. Can you just share what spread pricing is? I know that's one of the things that your bill looks to regulate.
Yes, so spread pricing is basically that the PBM receives payment for a particular prescription, receives payment from the health plan, and then pays an amount to the pharmacy. And there is a spread between the two. So they receive more from the health plan than they pay to the pharmacy. And that is there are various kinds of compensation that PBMs receive, which result in them pocketing a portion of a payment, whether it's that or via a rebate, and that helps drive up costs. And pharmacists don't get the full payment.
Thank you, Senator. And for the opposition, maybe if you can help clarify, one of our local pharmacists mentioned that they don't get fully reimbursed for some of the costs of the drugs that they are paying out front and are left having to foot the bill for the rest of the cost. Can you address some of those concerns?
Sure. So quickly on the spread pricing, I just want to point out that that is not required. It's an option to clients. They can choose spread pricing or they can choose pass-through. Some choose spread pricing because it provides them with more certainty on what they're going to pay, and they want that. So I just wanted to put that out there. To your question about the pharmacists being reimbursed less than what they might have been paid for that, we don't have a complete picture because their acquisition cost is in a contract between the wholesaler or PSAO, and so we can't on our own know for certain and reimburse them at a rate that fully captures that unless we have that information. Also, unfortunately, the biggest provision of this bill that I think directly helped the pharmacists was taken out because of the cost implications of that. And then what I'll say is, it's a contract by contract basis. And so, there may be situations in which the pharmacy is not being reimbursed or made whole. But the independent pharmacies are a huge and vital part of the pharmacy network. And so PBMs oftentimes, and we'll see this in the data, they're reimbursing some independent pharmacies far more than they're reimbursing affiliate pharmacies because they need them in their network. They have network adequacy requirements. And so I understand that there are probably, it sounds like there are situations in which they are not getting reimbursed and made whole. And that's certainly a conversation worth having. But this bill goes far beyond that and doesn't actually help the pharmacists, I think, in the way that would be most meaningful for them.
Thanks for sharing that. As a PBM, do you have access to these transactions, like that data?
The PBM would know what they're paying the pharmacy, but they wouldn't know what the pharmacy is paying the wholesaler for the acquisition of that drug.
Okay. I see some head nods. Did you want to respond?
I was just going to say, you don't have to wait for a bill or till 2027 to come and get data from me. You can bring a thumb drive by the pharmacy later today, and I will happily provide you with all of the financial data related to the prescriptions at my pharmacy to show you that I am not being paid more than the chain pharmacy up the street. But you cannot go into that pharmacy and get any data because they won't provide it to you. But I'll be more than happy to provide you with any data you would like. I may have already provided it to the state.
And I would like to second that. It surprises me because our contracts that we have are non-negotiable contracts. So we either take it or leave it contracts, which doesn't allow us much room to negotiate. And when we do negotiate, it's like 0.001% changes in the AWP pricing that we get or the MAC pricing that we get, which is, very foreign. I mean, we were talking about acronyms. So if either we take those contracts or we don't. If we don't take those contracts, then we don't get patients. If we don't get patients, we can't stay open. So I'll share with you all that. I mean, that's easy breezy stuff.
Thank you all for sharing your answers to that question. I don't have any further questions. Thank you to the chair, but really, just really wanted to understand the end user, the patient, and what the costs are that we're passing on to every patient to ensure that we improve the cost of healthcare in this country. And so appreciate the additional detail.
Thank you. I don't see any other questions or comments from the committee. Senator, would you like to close?
Thank you very much, Madam Chair. First of all, I also want to just recognize your work in this space too, and we've been working together on this for a few years now, and I'm very appreciative of that, and I look forward to continuing to collaborate with you to try to get this to the governor's desk. And with that, I respectfully ask for an aye vote.
We need a motion and a second. Moved by Schiavo, seconded by Addis. Thank you, Senator, for this, and I'm thankful to be become a principal co-author on this bill, and I want to thank you for your efforts in this on this measure. Please call the roll.
The motion is due pass to the Judiciary Committee. Bonta.
Aye.
Bonta, aye. Chen. Addis. Addis, aye. Aguirre-Curry. Aguirre-Curry, aye. Caloza. Caloza, aye. Rogers. Aye. Rogers, aye. Flora. Gonzalez. Gonzalez, aye. El-Hawari. El-Hawari, aye. Patel. Patel, aye. Ellis. Rodriguez. Rodriguez, aye. Sanchez. Sanchez, aye. Schiavo. Schiavo, aye. Sharp Collins. Sharp Collins, aye. Stephanie. Stephanie, aye.
That measures out. Thank you, Senator.
Thank you, colleagues. Thank you, Madam Chair.